I would like to welcome everyone to today's webinar presented by UASI. We have Staci Josten and Staci Pigott here to discuss with us pre-bill assurance. If you have any questions, you can submit them in the question tab at the bottom of your screen. And if we have time today, we'll answer them or we'll connect via email to get you a response. At the conclusion of the webinar, I will send you the slides from the presentation as well as your certificate of attendance for an ACDIS CEU. And with that, I'll hand it over to Staci Josten.
Hi, everyone. Can you hear me okay, Sarah?
Yes.
Okay. Hello, everyone. Like Sarah said, welcome to our pre-bill assurance webinar. And it's just been fun watching the names scroll through and so many friends, colleagues, coworkers that have joined and just really appreciate that. And so I'm going to get started, but I am not going to keep sharing my video. And so welcome and let's get started. So in the presentation today, we'll be doing 3 different sections. And the first one, I'll share an introduction talking about, what is pre-bill assurance, second level reviews. The second, we'll walk through a simple process of setting up and improving your second level review process. And then the third, we'll wrap up with actual examples, and you will get to meet the amazing Staci Pigott, the CDI director at Tallahassee Memorial, and she'll talk about her CDI program. Okay, so let's get started, and I like this representation of the past and now. I started in CDI 13 years ago. And when I started, our CDI program switched, it was just at that switch to MSDRGs. I only needed to review for proper DRG, PDX, and assignment of CC-MCC capture. I wonder if many of you can remember that. That's our past. Well, fast forward over a decade, now look at our expansion. And the list keeps growing. We have evolved and continue to evolve to a much deeper look at patients' conditions to accurately reflect their risk. It seems it becomes more and more important than ever for CDI specialists to understand how we can directly impact several areas within organizations. For example, clinical validation under the False Claims Act. It's prohibited to bill for a diagnosis that is not clinically valid. Therefore, we must perform a clinical validation query. Those are our favorites, right? Not mine anyway, but we have to do them. That's part of our job. Quality measures, working with our quality teams, identifying those hacks and PSIs to look for inclusion, exclusion criteria. We're out helping our case management team so that they can see that DRG assignment and the ALLS and the GMLOS. And so it just continues to grow, and I don't think it's going to stop growing. I think probably on the next time I do a presentation, I'm going to add social determinants of health. I think that's our next big expansion. So we continue to evolve in CDI, and I've used this slide for many years, and it's just helpful and an easy reminder for me that all things that documentation and coding capture affects. Nothing, is new to any of you probably, but just a reminder that it does the severity of illness, risk mortality, medical necessity, length of stay, reimbursement, reputable data, case mix, index, quality, compliance, and of course, denial prevention. When I see this slide, I just smile because it's job security for all of us in CDI and coding professionals. So I wonder if any of you feel like this, where we're kind of walking a tightrope and we're just always trying to stay balanced between quality and revenue. The CFO loves seeing that financial impact of the CDI team, and the quality department, they want every diagnosed represented for that risk adjustment. And it can be hard some days. And one of my favorite parts of my job is talking with and helping other CDI leaders with their programs. And I've seen it all, really. We see great programs that are doing, top-notch work. And then, honestly, we see some not so great programs and everything in between. And I've seen it where programs will put a little too much emphasis on just financial impact, and they'll put like every CDS has to meet a certain revenue goal. And, that makes me a little nervous. It's, sometimes quality suffers and may put your organization at risk. And then the opposite can be the other extreme where quality is, really pressuring you to send a ton of queries, right? And then the providers, like, okay, I've gotten 12 queries on this patient, and then they stop responding. There is a true thing of query fatigue. And so it's finding that balance. So I always like to remind ourselves it's a constant balancing act to keep that ultimate goal that of CDI, and it's to really get that accurate, complete clinical picture of every patient. And that's going to ensure that proper balance between both revenue impact and your quality data metrics. And so not only do we have all these other things that we're looking for, now our hospitals get grades, right? And so this, it just enters in our hospital grade example. And I tell the story often, so if you've heard a presentation of mine, I'm sorry for the repetition, but it was just kind of, it always just why this matters, right? And I was with my mom in the hospital, or she was at a cardiology appointment, and it was determined she needed a coronary angiogram. And she was going to be sent to a cardiac interventionalist. And when her cardiologist stepped out of the room, she looks at me and says, "Hey, Stace, let's Google the interventionalist name to make sure they have a good grade." And it just made me smile. So my, 78-year-old mom who, wasn't born with an iPhone, and, I've taught her how to text and get on Facebook, but she knew that there's grades out there for providers, for hospitals. And so people are looking, and so it does matter. I've listed here on what I believe are the 4 main publicly reported data sites, and each of them have a little different methodology. However, each of them have a component that is directly affected by documentation and code capture. So for CMS, there's a star rating. So 5, you get the best grades. You're on the A honor roll if you're in the green. You're, BC honor roll, average hospital, and in that light yellow. And then you're low, you're not performing well. You don't want to be in that orange. And so like the CMS stars, it's mortality and safety of care, hacks. So that's what affects their grade. Health grades, they use cohorts. I think it's 32 different health cohorts, and it's POA status. And I'll actually be giving a kind of a case story when we did for a client looking into their health grades, and finding out like things like DNR and palliative care in your top 25 diagnoses are really super important. And then Leapfrog, they use outcomes information from CMS. That hacks and PSIs are super important for that grade. And then US News and World Report, they use the Elix-Hauser diagnoses for risk adjustment. So super important to be familiar with those. So you can find all those methodologies. I included the websites for that, and it's fun to kind of look up your local hospital's grades and see where they lie. So it's important, the replicable data, Republic reported data, we, are getting calls a lot from hospitals where they really want to learn more about how they can help them, because we're going to make the assumption and we're going to hope that our hospitals are providing quality care. So hopefully that was, helpful, and you see our jobs as CDSs and coding professionals are of high value. And what we do is matters. Sometimes, I don't know about you that are have a nursing background, but I miss bedside nursing sometimes, taking care and helping people. But while working on this presentation and thinking about what we do, how it matters, we really do help our organizations get credit for the great care they are providing to our patients. So more patients will want to come to our hospitals, and the hospitals will get reimbursed appropriately. So not only will our jobs keep lights on at the hospital and help pay the bills, it would also help purchase that cutting edge equipment that maybe will diagnose somebody quicker or faster. And so I always just like to put that in as a reminder for what we do. So pre-bill assurance is maybe a terminology that you haven't heard of, or isn't always called that in the second level review process. And on this screen, you've seen all these words like retrospective, CDI, coding professional, quality review, clinical final review, all these kind of terminologies. And I was sharing this with our UASI's VP of Marketing and Sales, Mike, explaining about the different types and the various process. And he's like, so you're really looking at wanting to do a pre-bill assurance. And I'm like, you know what? That makes sense. That really should be the goal. We want to assure that before that bill goes out the door is that we're capturing everything correctly. And ideally, that would be post CDI, post code, and pre-bill. So you'll hear me throughout the presentation. It's second, they're all second level reviews, right? CDI coding's probably reviewed them once already. So you'll see me kind of switching back and forth between pre-bill assurance and second level review, but really it's that extra look right before it goes out the door. So the ultimate goal is to ensure that documentation and subsequent code capture reflects that care and treatment provided to all patients, which then you're going to get that your publicly reported data as well as your quality and financial reimbursement scores will all line up, right? So really to kind of just summarize this whole pre-bill assurance value, and I like the two heads are better than one. And for you trivia buffs out there, I was just curious, like, where did they get that quote from? And it actually is traced back to as far as 1390. So it's been around a long time. And I was thinking about this as someone maybe outside of CDI and coding might say, why don't you just get it right the first time? We're already paying CDSs to see this concurrently. We're already paying coders to review that. And, so why not? Why do we need somebody else to look at it? And, that's a valid question. But to give us all a little grace, there's more than 69,000 CM codes and 87,000 PCS codes to decide from. So hard to be an expert on all 156,000 of them. And if I could memorize them, I probably would not be in nursing. I'd be doing something a little, using my brain a little differently. But just for an example, my clinical background was in cardiac trauma ICU and pre and post cath. So cardiology was my jam. That's where I feel comfortable. However, my first CDI assignment, we were assigned by floors and I was assigned an oncology unit. And I am confident I missed things at first not because I wanted to, but because there was so much to learn on oncology and you just couldn't learn it right away. So most likely all of you have been inexperienced at one point. We have staffing turnovers. It takes 9 months to a year for you to be really comfortable as a CDS. And of course, we have let's just be honest, we have staff sometimes that are a little subpar, right? And they're reviewing records and we don't have time to, our leadership teams aren't set up to review every single thing that our CDSs are doing. So there's great value in this pre-bill assurance second level review. Accurate reimbursement, improved expected mortality, avoidance of denials, appropriate risk adjustment, accurate reflection and quality, and publicly reported data, that clinical validation. And of course, it also helps provide feedback to CDI and coders for educational opportunities. And something I put this slide and I was kind of debating about that, but I do get the question from clients, what's the difference between the second level review and the CDI audit? And both of them have absolute value, but different process and focus. So just that compare and contrast. So ideally that pre-bill assurance process would be post CDI coding pre-bill, where the CDI audit is more retrospective. And the focus of a pre-bill is, really looking for potential opportunities, looking for that completeness of the record, where the CDI audit is looking at CDI, individual CDI, and program performance. And then the pre-bill assurance is ongoing. That's those second level reviews. There's targeted areas, but that process continues. And typically CDI audits are, they're just performed 2 to 3 times a year. And they include things as, not only missed query opportunities, but also query compliance and process review, like timeliness of initial review and follow-ups, and absolute value in those audits as well. So if you and your organization have any questions about CDI audit, shoot me an email and we can talk about those on a separate call. So the pre-bill assurance really has three different kind of buckets. And I feel like their mortality, targeted work list, and then that diagnosis are project specific. We'll discuss some actual case examples later. And if you're not doing a mortality review process, this is the first place to start on your second level pre-bill assurance process. And just a little about the importance of mortality reviews and why that focuses is CMS, which is like your Medicare patients, they use data to either reward your institutions or penalize them financially under the value-based purchasing plan. Other companies, commercial payers, use data mining from MedPAR data using hospitals' mortality scores, comparing one physician or organization to the other. So hopefully you've all heard of ODE ratio, that observed over expected mortality index, but just in case you haven't, the quick version of that is the O stands for observed mortality, the actual number of patients that died in a specific time frame, and the E stands for the expected mortality. It's that average expected number of deaths upon a certain diagnosis. So that index or ratio is calculated by dividing the observed mortality by the expected mortality. The lower the score, the better, right? If you're less than 1, indicates that less people died than expected at the hospital. And that's, the ones we'd want to choose, right? Or if the number is greater than 1, then more patients died than expected. Now, we might be able to make an exception that maybe their documentation isn't as good and they actually do provide quality of care. But I don't know about you, but that's not a risk I'm willing to take with a loved one. So, that mortality is really, you can Google your hospital and like, what are their mortality scores? And it's really important. You don't want to go to a hospital for your appendicitis and, you're not expected to die. So, looking at those, it's really important. And so that's where the mortality is. And, start without, those mortality cases without a CC or MCC or an SOI or ROM less than a 4 and a 4, and maybe that's too much, right? There's too many, you don't have enough resources. So maybe you just add deaths in low risk surgeries, or maybe ones with just an autopsy report. So it's just a good way to kind of get started. The second one is a targeted work list. And, that's those outside, your patient was, their GMLOS was 5 days and they're still in the hospital 8 days. There's no CCs and MCCs. What's keeping that patient? So you want to look at that closer so you can get some of those extra, see if there's any extra diagnoses that need to be picked up. And then also the SOI ROM less than a 4 and a 4. And I'm talking with different clients and staff, and it can be creative. I've recently learned that, maybe just even doing cases with pathology reports, there's sometimes a lot of opportunity that doesn't get picked up in those, is another way. So, just talk within your organization to learn about what list that you can target from. Another little thing, I recently had a conversation with a quality director, and it was a really interesting conversation because we were talking about second level reviews. And she was like, from a quality standpoint, your work lists don't, show anything of, risk adjustment. And, it's hard to get a work list created on things that aren't there, right? Like you don't have your risk adjusted, like if you're depressions, if it's not documented, it's hard to pull in that. And so what I was explaining to them is, this list helps create patients that likely have or could have an opportunity, but you're still looking for all of those risk adjustment type of diagnoses to add, even though it's really hard to create a list specifically for those. Hopefully that makes sense. And then the third bucket is the diagnosis or project specific work list, those known problem areas. This is where UASI gets called in, and these are really super fun for us because it's just really doing a deep dive. I'll share an example of, a cardiac group requested us to do a deep dive into some of their patients. We had another client want to look at their publicly reported data. And we did like a health grades audit. So I'll share more about those. But, if you're in some meetings and your hospital struggling with an issue, it might be just a select pilot to see, okay, is this an issue or is this not? And, we always, from CDI, always like, okay, if we just document better, it'll show better. But, sometimes there is a provider or something that isn't providing the best quality. So we have to, keep that in consideration too. So that's just the overview and understanding of terminology. So we're all on the same page before I start jumping into a strategy. But before we do that, I'd love for us to do our first of two surveys. Sarah has the survey up, and you'll see if you could just type in your poll of, does your organization have a second level review process? And one, yes, you're knocking it out of the park. And so after this presentation, you're going to email me on the things I missed, or things that you think really help make your program the best. And then two, there's room for improvement, right? You've started, but we don't. And then three, nope, and no plans to start, and no, or no plans to start. And then four, no, and planning to start. And then five, you're unsure. I'm going to just give everyone just a few more seconds, and then we'll look at the results. Okay. Thank you so much for answering. So 18% of you are yes, knocking it out of the park. I'll have to be honest, it makes me nervous because it's awesome. But then I'm like, I'm really curious on your feedback of this presentation. So there'll be a survey at the end. Please put your feedback in and tell me something that I missed on this presentation. 55%, that's the majority. There's room for improvement, and rest assured, you're not alone. That is the case. There's always room for improvement. 8% no, and no plans to start. That's interesting. Kind of curious about that. And then 6% of you know, but planning to start soon, and 13% unsure. So thank you all. That's just interesting to just see where the audience is at. All right. I think I have to close up. There we go. Okay, so hopefully it's clear that absolute value and a need for a pre-bill second level review process, but how? We need a good strategy to make it successful, and I love a good process, even better a to-do or checklist. I wonder how many other type A nurses out there enjoy that. Probably goes back to our days of nursing school, learning that nursing process of assess, diagnose, plan, implement, and evaluate, in those long hours of working up care plans, right? But for an efficient and effective second level review, let's keep it simple and straightforward as possible. We'll spend a little time on each of these: plan, target, track, evaluate, and improve. In the beginning phase is planning, and it's where we define the process. And I like good quotes. If you've ever attended a presentation of mine, you'll sure to hear some. And Alexander Graham Bell says, before anything else, preparation is the key to success. And that, I believe that's really the key. And if you were wanting some fancy algorithm or black belt methodology, you might want to multitask here for a little while, because I like simple. I think it's fun to brainstorm with clients and colleagues, and I like it to, just be straightforward, nothing complicated. So I'm going to go back to the 5 W's and the H. We probably learned that. I Googled, like, what year do you learn that in? And I was thinking like middle school, but it was actually preschool. So you know what? This is as simple as it gets, right? Who, what, when, where, why, and how. So the who. The who is probably one of the most challenging. Some of you are probably thinking, because as you read, the who is the most experienced person you have, somebody that's well-rounded, who can really, jump in and dig in, and you're like, my goodness, she is out of touch. I can barely keep my concurrent program staffed appropriately. How are we going to move my most experienced person to second level reviews? And I hope I'm not out of touch. And I realize that staffing shortages are real. But these reviews are super important, and you may want to, seek approval for a vendor. I'm going to do a selfish plug for my UASI CDI team. We love helping our clients with CDI, staffing, audits, second level reviews, and CDI education. I am beyond proud to represent our most amazing leadership team, as well as our many experienced, exceptional CDI staff and auditors. So, if you do have that need, don't hesitate to reach out. Commercial's over, had to put my own plug in there, but that ideal resource really is that very experienced, broad range knowledge person on multiple conditions, and enjoys collaboration with coding, quality, providers, AKA they can get along with others. That there's it's not black and white, right? There's a lot of you have to be okay with to agree to disagree on things. And so it really is that type of person. The what I like some of the, and so each of these are just some, easy questions to start asking yourself. And what is the goal? What kind of goal do you want to have for your second level pre-bill assurance team? Knowing what your goal will be will help you define your success at the end. Then when should you start the process? When should each step of the process occur? The when is, you don't want to start this at the beginning of an epic conversion or any of those type of things. Look in your calendar, summer vacation, a lot of people are going to be gone. Think about that, and you want to start it out to be successful. Where should the process start, and where is the place needed to see the most improvement? And that's kind of like deciding what that targeted area is going to be. And just any kind of things, the questions where was kind of hard, I'll be honest. I wanted to leave that one out. But why is the process necessary? You always want to know the why, so that can be front and center when you're going down different rabbit holes, and that can bring you back. And then it's also important to think about ahead of time, what are those challenges and what are those roadblocks that you anticipate having? A lot of times it comes down to funding and budgeting and resources, and like talk about that. Who do you need to get approval from? And then how will you use technology, that's important, and how will you know if it's successful? You want to be able to define that success up front so that you can celebrate the successes that you see in your program. So let's say you have you started to brainstorm. Here's your brainstorming. You sat in a room with your leadership team, or maybe if you're a small CDI shop, you grab your most experienced CDS, your favorite coder, and you start brainstorming. And maybe it looks like this. This is what you decided. You're going to look for that experienced CDS, and you're going to communicate with your CDI, your coders, your quality, and your provider, maybe your physician advisors involved. Your what, you decided it's going to be a pre-bill assurance, and its reason is you want to get accurately reflection of your coded data, and you're going to look for additional CCs, NCCs, HCCs, Elix Hauser diagnoses, and then you're going to look into getting a Vizient calculator. The when, post CDI review, post code, and pre-bill, you're going to create some work queues, and you're going to define a timeline. I always, the whole DNFB, DNFC, like, oh, you're going to hold up the bill. And I think, a lot of organizations, it's kind of that 4-day, maybe it's 72 hours, and, everyone's anxious to get those bills out the door, which, when hospitals are, struggling financially, I get that. And so I always, when you do start a process, and if you are holding up bills, know what your DNFB is before, right? Know what that, if it's 4.2, whatever, and you're increasing it by putting this process into 4.5. Well, did that make a difference? Now, if you're increasing it, by a day or two longer, then you're going to have to speed up that process. So, it is a timeline, and the clock is ticking. So your pre-bill assurance team, really does have to be able to cover when people are on PTO. And I don't ever really like to make people work on weekends but there's people that like working weekends, right? Like they want to have a day off during the week. So find those so that you can not have any of those down days. So that's the when. The why is the process is needed to, really want your publicly reported data scores. And the problem is you won't, that all that stuff is delayed, right? So the data that sometimes is released is a couple years later. So you really want to make sure that you have some, reasons why that you can see in the short term and you can see in the long term. And where you're going to start, you're going to look at mortality cases, and then you're going to look at some DRGs with high denials. You're going to also look and leverage the use of your current technology software. And if you don't have no technology, don't worry, there's other ways, and I'll show you that. You want to track, and we'll talk a little bit more about that in that section. And then success will be measured by your increased reimbursement and your increased diagnosis capture. So you did some planning, and then your process is coming together, and so maybe it's helpful to map it out. a little bit, and several of our UASI CDI consultants provide staffing support who have robust processes like this. And I just really a simple map, but it really is important to see, see it how it can kind of flow, right? And why ask both CDI and coding to review again? And so my background is clinical. So when I review a patient record, I am looking for what's not documented from a provider documentation. I'm looking at tests and lab results, medications. I'm on the hunt for a query opportunity, an effort to better tell the patient story. That's how I would really say that's what CDI's focus is. My wonderful colleagues in the coding profession, they are masters of those 156,000 codes, all the rules, regulations, and clinics that go with it. They have to code from what is documented. And so I have seen nurses that make phenomenal coders and coders who make fantastic CDI, and the rare unicorns that can do both at the same time. I'm not saying it can't happen, but using your brain two ways, it's completely two different ways of thinking. So if you have one of those unicorns, consider yourself very lucky, or if you're one of them, give yourself a pat on the back. But for the most part of us, we think either clinically or from coding standpoint, and we have, obviously CS has to know some coding stuff, and coding obviously has to know a lot of clinical stuff. But your really focus is different. I want to look at for what's not there, and coding is looking for what is there. So, so here on this process, so if you're thinking of setting up a pre-bill assurance, this process is really top notch. The patient's admitted, CDI reviews the chart, the patient's discharge, coding codes, and then the retrospective work queues begin, and you decide what goes in there. And then the retrospective clinical review, they review records and they're looking at the codes for additional documentation opportunities and the things that they focus on, not that it's coded right, but like POA status, clinical validation, those types of things. They send the queries if needed. That's why you need to have that physician buy in, your physician advisor, because these are queries we want really responded as fast as possible, because we're not releasing the bill until that. And then as soon as we get what we need, we notify that retrospective coding team. They make the updates on the codes. And if they have a question, then they have their go-to person on the pre-bill assurance team that they can resolve that, collaborate together, update the final codes, and release the record for billing. And ideally, this would all happen within 4 days, but we live in the real world, and as fast as possible. And sometimes, if queries aren't answered, you might have to bill, release the bill. I just always cautious clients to do a lot of rebilling. I feel like it might put you at some undue risk. We've seen that a couple different times, but we know that it happens and it can, but just not to have that as your go-to always plan. So then target, that's our next step. And another challenge I see with clients is that it's, where do we start? And sometimes I see I'm starting too big, right? Where you're wanting to review everything. And obviously there's just not enough resources. You can't review every single discharge. And we talked a little bit about this, but here's just a little bit more of an expanded list. And, start with a couple, like I said, if you're not doing mortality reviews, that's the place to definitely start. Then keep expanding and looking to see, okay, are you having findings? And if you're not having findings, then, okay, we don't need to review that as often. Sorry, I just remembered something. I want to go back to this slide. The one thing that I meant to do earlier on this slide is I wish I would have put a circle right here. And I wish I would have said education, right? Because the last and the final step is these findings that you find on your retrospect pre-bill team, those topics really need to be brought back to your CDSs and your coders, because your concurrent ones, because that's the whole thing, is you want them to continue to learn so that, that this team, should actually see a decrease in amount of queries they need to send because they're done concurrently. So, if you're taking notes, put a little education bubble here because you want to educate on those topics. And I'll show you that in just a minute about tracking. So for the targeted case selection, you can kind of read that here, just some ideas. And, expand, learn from your organization where there's some struggles, and put those in your work queue. So tracking data is kind of one of my favorite things, and data tells the story. This is that strategy that will really help make sure that your pre-bill assurance resources are a value to your organization. And so by tracking what's being done, how many records are being reviewed, and what's that impact will help. And so some quick tracking tool tips is assess current tools. You pay good money for your CDI tool, your EHR, so reach out to your contacts there to just see if your tool has any retrospective review functionality. Figure out what you need for reporting and keep that in mind when creating a tracking tool. Start simple, keep expanding. Every data element takes time to review, so scrutinize any add-on elements. Separate your nice to have to your need to have. Sometimes I just don't like it when we put in things in our spreadsheets or things that if you're not, every data element should be of value and you're using it for some reason. Ask for feedback for the people that are using the spreadsheet and from the people that are reviewing your data. What else do they need? What's not working? What's working? Create some detailed instructions so that you can ensure everybody on your team is following that same practice. If you don't have a tool, don't fear. There's always Excel spreadsheet. My team knows that I love creating spreadsheets, probably to a point of annoyance. But here is a simple spreadsheet with some headers just to get you started. And each of these all mean something, right? So who is that second level reviewer? How are you going to identify the patient? I always think the payer is nice because, sometimes there's different methodologies there. You want to know the CDS because maybe there's a trend with a certain CDI about, not capturing something. Same way with the coder. I like to know, what was the initial MSDRG, and I like to know the relative weight. So this is all, basically data entry stuff. This is how it comes across. Then your second level reviewer comes in here. And then I would just say, like, this would start with the clinical pre-bill assurance person. And if they find a coding interaction topic, we sometimes at UASI call them documentation capture. Everything's there, but coders are human, CDSs are human. We didn't pick that up. Or, hey, we found a diagnosis in the number 35, and we really feel like it should be brought up to the top 25 because we know that's what gets submitted. So those type of topics. Same way with the query opportunity topics, like, is that respiratory failure? Is it, malnutrition and that type of thing? So you can know where you want to do your education, and that'll show on the next slide. Who is the provider the query sent for? Who is the query answered? And then the impact. This is a simple way to understand what type of impact that you're having. And it helps remind the second level reviewers, like, okay, whatever impacts are important to you, that's where they would. So if you don't want the 8th CC, then, we don't put the additional C. There's just different things. What's of value to you and how you want to get the data out of it. And then I think it's imperative that you keep the impact of those, and you can autofill the title and the relative weight, and then every month you should summarize your relative weight, multiply that by your hospital's blended rate, and then that's going to talk about your return on investment for your second level reviewer. And that's just super key. And so then I would share something like this with my C-suite each month, where you would put in, your financial impact. And I bet when financial impact sometimes brings out with CDSs, we all kind of struggle about, I thought we were going to balance quality and reimbursement, but now you're telling me I should, call out the financial. Well, I tell you, you need to capture it because it's job security by, showing in your financial impact data with the C-suite. It shows the absolute financial value. And at times, like during the pandemic, when hospitals were forced to downsize, the clients that were able to show their financial impact, both from their concurrent and second level reviews, we're able to stay because the C-suite knows that CDI is revenue generating, and that's an absolute asset to the hospital. It makes me sad when I hear, yeah, we're down 4 CDSs, and I'm like, wow, your hospital wants to be down that many CDSs when we know that CDI does revenue generate, and generate revenue, but we also don't want to be known for that only, right? And we bring a lot of quality aspects as well. So, and the difference between positive financial impact and a negative financial impact is, you just want to be good partners and, be honest, is because the negative impact is when you're, for example, the MD writes acute respiratory failure and there is no clinical indicators to support that diagnosis. So you send that clinical validation query and say, hey, doctor, you documented this, but I don't see anything to support that. He picks up the phone and says, my bad, I'm human. I didn't mean to start that on the patient. And you're like, okay, thanks. It's just a documentation issue and you don't ever take out the wrong limb. But anyway, that, okay, so then that's where that would be, because it was initially acute respiratory failure, but you sent a query. So then you're taking that off. But that's still, bringing quality, and hopefully you don't find too many of them. So, the really key is to make sure you have financial impact evaluated. So that talks about evaluation. So the fourth step is to evaluate and collect and analyze data. Start weekly and then, maybe go monthly. And like I said, in the tract and trend, definitely the financial impact, but also the educational topics. Because like I said, you really want to bring those forward to your concurrent CDI and coding team. And if you, educate on those common things, ideally that pre-bill assurance team should see a decrease in queries because it's captured in that concurrent review. So here's an example of how you could do the educational topics. Let's say you had, 100 queries that you sent out in January on your pre-bill assurance team. And 25% of them are clinical validations. So that's where you need education on, right? Like those are hard queries. Those are, I kind of always think of them as the next level of CDI. Once you get the basics, then you have to do that. But then there's also, blood disorders and malnutrition. And maybe it was a bunch of cardiac nurses like me started on your CDI team, and I was still trying to understand things on how to query for malnutrition and pancytopenia. So I was missing those things. And so those educational topics are really important to continue to monitor and evaluate. And then the last step, so progress over perfection, always room for improvement. The only constant is change, all that for some Thursday afternoon inspiration. Just kidding. But this step may seem a little odd at first. I'm just trying to get my head around starting a robust pre-build process. And then you're already wanting me to improve it. Well, no, I just want you to remember, get those first 4 steps down, but not to stay stagnant. Sometimes it's so much easier. We just keep adding on, adding on, adding on. But that doesn't necessarily make improvements. You have to just evaluate and then make those improvements, make efficiencies. And these are just some quick questions to ask. How well is that process working? Is the timeline working? Is the goal being met? Any way to make process more efficient or effective? And what is the ROI? You don't want to be doing something if you there's not a return on investment. So that is time for our second survey, and then we'll get into case studies. So if your organization, if you said you were doing second level reviews, what is the focus? Is it purely for financial impact? Is it for quality? Is it just mortality reviews, or is it all of the above, or unsure? I'll give everyone a second. All right. Everything's coming in, and it looks like everyone, I love seeing that. Sounds like the ones that are looking like so far, which there's still a few more straggling in, but 68% do all of the above for financial impact, quality impact, mortality reviews. That's great. 3% of you do it just for purely for financial impact, 8% just for quality, 8% just for mortality reviews, and 13% unsure. Well, thank you all for answering that. So I'm gonna, yeah, so you can see those, but I mentioned them. I can't go to the next slide without ending that. Well, so let's get to some case studies. Okay, so the first one is the pre-bill assurance was on a targeted work list. And this, we had a group of our CDSs really using that robust pre-bill assurance plan where it's CDI coders, there's a team of them. And so you can see through the steps that the plan was that they're going to use that team, and they are lucky they have some tools that they use, the CDI software for their target. They have some AI for the retrospective work queue. They did track the topics and trends and the financial impact. After that, they evaluated and they created education, and they're looking always for improvement, and they're going to keep that process, and then they're going to expand to other regions within their organization. And their case study results of those, so for our team, we have 4 people, and in a 4-month time frame, they saw 15 or almost 1,600 cases, 69% query rate. Quality elements they were reviewing for is SOI, ROM, ELIX, Hauser, and HCCs. And then you can see the revenue impact. This case study number 2 was again a targeted work list. In this one, a caveat on this one, this was interesting in the fact that we did this one over 4 months. In this, there's a lot of opportunity that was here on this one, and there was a lot of new CDSs on their team. And so that we used 2 UASI experienced CDSs. They worked with the hospital CDI team and the coding team for a collaborative process. They did the post CDI and post code and pre-bill. They captured cases without CCs, MCCs, the SOI, ROM less than a 4 and a 4, and they were outside the GMLOS. They used Excel, so it works to track it in a spreadsheet, and they did that, kept for their topics of their queries, and you can see that here. I always just thought, it's kind of interesting to see what you find. And then the financial impact, and you can see that it was over $1.2 million for those cases, $971 per record. So then that was how they can provide education for the concurrent staff. And then they were able to, they modified the spreadsheet, and they started more orientation, and then they used some of their current experienced CDI staff to take over the process. This was the one I was talking about earlier, that it was a cardiology group where CDI wasn't reviewing. They were only reviewing just part of their cases, Medicare, and they wanted to expand to their non-Medicare patients, to all payers. So it was really, and have asked from the cardiovascular service line, which was right up my alley. So maybe that's why I love this one so much. But there was a work queue that was created to target, and we created targeted AFib, circulatory, heart valve, MI, and valve procedures. And we tracked the topics and trends as well as SOI, ROM, ELIX, Hauser data, and Vizient impacts. And you can see the results. It was pretty eye-opening, and there is definite value in reviewing those other commercial payers. And so we fine-tuned the process and narrowed down the case selection, so it wasn't as which one, and I can't remember which groups there was the most impact in, but then continuing that process, and it really was the case to help expand the CDI program to review all payers, especially in this cardiac vascular work area. And the last one, I'm going to go, and then I'm going to have Staci P join me. And I always try to rehearse these, and I didn't rehearse it in usually I talk really fast, and I'm sure I did as well, but I'm like, oh, I'm getting close on time. So these last slides, I apologize for kind of speeding through, but um, this was the ones where a hospital wanted us to look. They were disappointed in their health grid score, and they wanted to, try to get ahead of it and try to understand what that was. So we reviewed 75 patients, and this was just a pilot study to, see if there was value in their pre-bill assurance thing. And so we were looking at the health grades cohorts, and then we were looking at POA status, and really that again, coding is looking at what is documented, and CDI is looking at what's not documented. And we really kind of found a lot of different opportunities in POA. For example, like acute respiratory failure is where if 3 days in, the doctor might have, said that, but the clinical indicators really showed in the ER that they already had it and they just didn't document it at POA. That DNR palliative care, sometimes that gets missed to make sure that that's in that POA says, is it? Yes. And then that is captured in the top 25. So you can see where, that DNR, sometimes it never really used to matter and it didn't need to be captured. And so then now it's really important that it does get captured. So there are some great findings. And so then, there was definitely enough opportunity. So the improvement they're moving it to a pre-bill process, and we're going to continue that process. So now I'm going to turn on my video, say hi again to everyone. I hope you're staying awake and you got some coffee or tea. And I am just super excited to introduce to you my colleague, Staci Pigott from Tallahassee Memorial Healthcare. Staci has been a UASI client for, I think, 7 years, because I started almost probably 8, because I started at UASI. I'm on my 8th year, and you were already clients with them. And Staci was recently promoted to CDI director, so congratulations for that, and welcome. So tell us a little bit about your CDI career and how you got into CDI. Oh, I think you're on mute, Staci.
I was indeed.
Okay.
So hello, everyone, and thank you for having me today. So I started my nursing career back in 1991, and I was an oncology nurse for many, many years, and then transitioned to CDI back in 2013. So I've been in CDI for a little bit now, and I was the manager of the department starting in 2015, and most recently was promoted to director back in January.
Great. I could have used your oncology when I first started CDI. That would have been super helpful. And talk about your CDI department and the tools that you get to use.
Sure. So we started very small. Our area started back in 2010. It was a physician-led initiative, and at that time we had 6 staff members. And initially, we're just, as Staci mentioned earlier, doing reviews for, present on admission and MCC and CC capture. And then, and at that time we were reporting to finance, and then UASI came in to do a revenue cycle audit for us, which we're super grateful for, because it has allowed us to really make some changes with our department since that time. So one of the biggest things that came out of it is that we now report to our quality department and are using our CDSs to perform some of those quality reviews.
Great. Well, thank you, Staci. And yeah, we've partnered, we did the assessment together, and we've done audits. And I have to give a little shout out to the 4 CDSs that work with you, Liz, Chris, Justin, and Terry, right?
Absolutely.
They've been with you for a while.
They have. And so I guess I didn't answer the other part of your question, which was We have, as a result of the survey, we now have 11 CDSs on staff. I have 3 vacant positions, and then of course have our 4 UASI people. And Justin and Liz have really been with us since almost the beginning, since 2015. So
yeah, so it's been fun, a lot of fun partnering with you and your team. And so let's look at really you and your team have been, kind of really cutting edge. What I would say is, at this whole mortality review, you've been doing that for a long time.
we really have, even in our very early days. So we understood then, even in 2010 when the program started, we understood that reviewing those mortality records was super important. So at that time, we, everybody in the department was taking a shot at it, and made some definite impacts. And then as we transitioned to additional staff, we just have a couple of people right now who are focused on those mortality reviews, and it has significantly, I feel like, improved our severity of illness and risk of mortality, and helped certainly on the revenue side as well. So we get a daily list of all expired patients, and we review those. And we, of course, look for any opportunity on the account, but severity of illness, risk of mortality, and make recommendations to the coder, and then they can either agree or not. It's it's up to them, but I think at this point they definitely are in agreement 99% of the time of what we have recommended, that they what they look at and what they're doing with the codes.
Great. Yep. And that's perfect. I look at your process and look at the results. So 2 of our CDI consultants do, Justin does the majority of the mortality reviews, and Liz does SMART reviews. And then the other 2 will kind of fill it. They'll do staffing, but I think they're doing some backups and that type of thing.
Absolutely.
I saw the question on what we do. So really, when we provide staff, they say they can be your utility players wherever you need them. That's where they go. And so you can see just in a short amount of time, just for the Justin keeps track of his data, and really just shows on that 721 cases reviewed that impact, right? And that's important to your organization, right?
Without question. We really, all of the staff at UASI are invaluable to us, and the work that they do. And so Justin and Liz specifically have really helped to impact our second level reviews.
And then, every once in a while we get special projects, right? Where you're like, hey, we want to look at something. And we we do this diagnose. Here's another example of this, like, diagnosis specific kind that we talked about. And it was some cardiology procedures, right? And
right. So, and we, so the reason we started doing this is because we were having some denials associated with our cardiac program. And so we worked with the physicians to for them to understand the importance of the documentation, really what needed to be documented. And then as a second level review, we came in and just shored up the chart. And so again, we knew exactly, with working with the cardiologists and their team, who those patients were. And so the specific patients were our TAVR patients, mitral clips, the Watchman, and those real high dollar specialty procedures that we were doing at the time and continue to do.
Yeah.
So definitely had some positive impact there, and our physicians were super grateful.
I love that. I just think that's a neat way to show that how valuable that second level review is, kind of on those special projects, and really working together. So, I hope I didn't rush you, but thank you, Staci, for joining. I just, I can talk all day long, but just getting some real life examples, it's just really nice to see. And it's been wonderful to be able to partner with you. And thanks for jumping on. I appreciate it.
Absolutely.
All
Thank
right.
you.
You're welcome. Well, I about timed this accidentally on purpose at the amount of time. So just in closing, I just want to thank everyone for their time. I hope you have a wonderful, rest of the spring. I'm excited living in Iowa. I'm looking forward to getting some leaves on the trees again. But I hope that you all will walk away with a few tidbits that you learned today. And, if you do need any help or want to have further discussions, I love talking about this stuff. If you hadn't noticed, I'm kind of passionate about it, and just really, UASI is here to help. Like with Staci and multiple clients, we're here to support in any way we can. And if you have any questions, or just either put them in your survey, that will be a quick way that I can respond to you. Or if you need help with resources or CDI resources at all, or getting started, you can do sales at uasisolutions.com, and that will also get routed to some people that can help you as well. And so that I'm going to turn it over to Sarah to talk about last steps, but I hope everyone has a fantastic day.
Thank you, Staci. From what I can see in the chat, you just gained a LinkedIn follower. So
Okay.
Staci is on LinkedIn. You can follow her there. Thanks everyone for joining us today. Like Staci mentioned, there will be a survey going out in an email, as well as you'll be able to download the slides from the presentation and download your ACTA CEU certificate of attendance. So you'll see that come through your email, the same one you used to sign up for this webinar, in probably the next 30 minutes. So look out for that, and thank you all for joining today. Have a good rest of your afternoon.
Bye, everyone. Thank you.